So firstly, we're going to hear from Stephen Muething, who is actually currently Vice President for Safety at Cincinnati Children's Hospital Medical Center in the US. He's also a clinician. He's an Associate Professor of Pediatrics and currently a practicing hospitalist, or I believe it's a consultant. He spent the first decade of his career working in pediatrics, and then more laterally, over the last decade, he's been involved in a number of different transformation projects, including a focus on patient safety and patient quality. And he has led a number of different national sort of initiatives in terms of how to further the patient safety agenda. So we're very pleased to welcome Stephen to our meeting today.
Just here. Okay. Good morning, all. And thanks for the great hospitality we've received, and thankfully they closed before the conference started this morning. So that was our timing. And it's just been a great visit. I did tell my wife I'd bring her some pictures. I didn't think it would be of me, but this morning I'm just going to spend a little bit of time sharing some of our work from Cincinnati Children's that's spreading now across some of the children's hospitals in the United States. And I propose that it comes from the belief that, as the question is posed up here, what if we never harmed a patient? And achieving that is obviously very complex. It's a journey, but I think the first step is really starting with the belief of that's possible. And so what I'm going to do this morning is just share some brief background. I'm going to spend the majority of my time explaining what we've done because it was concepts that we were not familiar with, and I want to make sure you understand why we've chosen to do what we did, and then I'm going to end up with some data. And then hopefully throughout the day we'll have some time to discuss this. Feel free to push back or pose questions. So I am at Cincinnati Children's, and we're an organization that is on a journey. We're about 15 years into a transformation journey to becoming a continuously improving, a continuously learning organization with some bold goals. But our vision is to be the leader in improving child health, and the only way we know we can do that is both by learning how to improve ourselves, being transparent with our outcomes, which are not always as good as we want them to be, but particularly learning with others, both across the United States and here. And we've now created a network of over 75 children's hospitals that are all sharing our serious harm data together with a goal of eliminating serious harm together. And I hope in the near future we'll be doing that across the ocean with all of you. Cincinnati Children's is it's a large organization. It's just for the children's hospitals. We have 500 beds. We have 13,000 employees, and we have a large research facility. And we've been growing a lot. And we used to just be a nice little children's hospital for our region. Now we see children from 50 states, all 50 states, and over 50 countries every year. So safety has become a much more daunting problem for us over the years. Just in case you weren't familiar with where Cincinnati is, I figured I'd show a map. We're right there in the Midwest. I always just tell people we're somewhere near Chicago. Cincinnati, of course, you may not be familiar with it, but I bet you are with some of our companies. P&G is in Cincinnati. Macy's is in Cincinnati. And then, of course, we're also notorious for having Jerry Springer was a former mayor of Cincinnati. Every place has its good and bad. So let me just propose, we faced the question about 3 or 4 years ago, what if we never harmed a patient from delayed recognition of clinical deterioration? And the reason we proposed that question to ourselves is we looked at what was going on at Cincinnati Children's, and every year we had about 10 serious, we call them codes or cardiac arrests, and we actually had about 2 children a year that were seriously harmed or worse from delayed recognition of clinical deterioration. And I think when we looked backwards, we thought maybe that's just the way it's supposed to be when you take care of complex kids in a large organization. I think we accepted it for decades. But we started to really ask the question, could we stop that? And when you start asking that question, you start trying to figure out, well, we don't know how, and we really need to start finding people who think differently than us in order to help us push this. So we knew it would be some combination of this vertical work, which is the focused on specific types of harm, whether it's a central line infection or getting hand washing right, or in this case, trying to figure out exactly what it should look like to prevent harm from clinical deterioration. But I put the horizontal circle there is to say that's all enveloped in the culture we're trying to build, which most people call safety culture. We've come to call it a reliability culture. But we knew it would be some combination of that, but we really needed to learn more about what this could potentially look like. And so we spent a lot of time learning from other industries, particularly in the United States. We spent a lot of time with the naval aviation, the aircraft carriers, and nuclear engineers. And a friend of mine who's a nuclear engineer who's now trying to apply a lot of their learnings into healthcare, his name's Kerry Johnson. He works for this company, Healthcare Performance Improvement. I have to give him credit. He taught me this slide, and I would say in essence, this is Cincinnati Children's safety journey. And the lowest curve there is trying to reduce harm through process reliability. That's knowing the bundle for bloodstream infection or knowing the bundle for ventilator-associated pneumonia. And we did a lot of improvement work along that line and reduced significant amounts of harm. But it was this second curve, which is really this reliability culture, which is present in so many other organizations that we really thought we needed to learn more about. And so that's what I want to give you just a little bit more background. And we actually studied the work of many people, but I have to really give credit to Dr. Carl Weick and Dr. Kathleen Sutcliffe, who are actually from the University of Michigan School of Business, the Ross School of Business. And Kathleen, I have to say, has been a world of help for us. She's visited us a number of times, and we've gone up and see her. But she and Dr. Weick did some very fascinating work, and I would encourage you to read this text if you get a chance. It's a pretty easy read. It's called Managing the Unexpected. But what they did is they studied high reliability organizations, and by that they described these HROs as dealing with environment rich for potential for errors, unforgiving social and political environments, learning through experimentation is difficult, complex processes, complex technology. And they studied aircraft carriers, they studied nuclear power plants. But when I see that list, to me, it feels like they were describing hospitals. It felt very familiar to us. And what they did is they studied and found that those organizations had 5 characteristics that together they call mindfulness. But they said that they could see these 5 characteristics different than they would see in all the other organizations that they had studied through the Ross School of Business. And the 2 that I'm just going to draw your attention to are number 1 and 3. It's a preoccupation with failure, which to us used to mean that we were happy if we knew that we had harmed a child. But HROs go much further than that. They're not just satisfied with knowing when something went wrong that caused major harm or major problems. They want to know about every little thing every day. And as Kathleen Sutcliffe taught us, HROs not only like getting it right, they hate getting it wrong, and getting it wrong with little things. They constantly are trying to learn from mistakes or near mistakes every day. And then sensitivity to operations, which I said 3, but it's 2, is the concept that in HROs, the organization has figured out that the only reason the organization should exist on a daily basis is to help the front line get it right. And get it right now, today, right this minute. And so they are, at the nuclear power plants or an aircraft carrier, they're not thinking about monthly charts or thinking about trends. They're thinking about what do we as an organization need to do to help our front line get it right this minute. What's going wrong? What potentially might go wrong? What help do they need? And I have to say, historically, Cincinnati Children's was not that kind of organization, and we're trying to learn how to be that. So let me get specific about why we pursued this. When we looked at our serious incidents over about a 2-year period, we found that half of our harm, serious harm, was being caused by delayed recognition of deterioration, or as we came to understand, poor situation awareness. And we knew that if we were really going to continue to reduce our serious harm, we had to focus on that and learn. So let me tell you what we learned about situation awareness. We really learned most of it from the military, and for those of you familiar with it, the easiest way to think about this is Tom Cruise and Top Gun. And the way the military started, historically, they had always thought, well, some pilots have the it factor. They just seem to know what's going to go wrong before it happens, and they always seem to know what's the right decision to make. And at first blush, you would think, well, what does that have to do with us? But when we start thinking about it in healthcare, we've always kind of had that same belief that some nurses and some physicians just seem to know what's going to go wrong before it happens. They always seem to be at the right bed at the right time. And I have to tell you, I think in retrospect, our strategy for hoping we never had a child with delayed recognition of clinical deterioration was just hoping those Top Gun nurses and Top Gun physicians would never go home. But what we realized is that most of the time we do get it right. Most children go through our hospital, go through very complex surgeries and treatments, and go home. But it's that 1%, or really less than 1%, maybe even as small as 0.1%, that we can't tolerate anymore. And what the military came to understand is it's not okay to just have our Top Gun pilots. We need to understand what they think, why they make these decisions, and we need to build systems so that everybody has the it factor, or as they came to call it, situation awareness. And here's how it looks like in healthcare. Most kids, at least in pediatrics, I know it's a little different for adult care, but most kids come into the hospital, they're sick, but we know they're going to get better. We just have to make the right diagnosis. We need to prescribe the right treatment, do the right surgery, and most kids follow that green line. They come in sick, we can see the fact that they're going to get better, and we predict they're going to get better. But not every child does, and that's the red curve that falls. And we thought about what we had done historically, and it's easy to see that a child fell off the curve when they go all the way to the right there and they have a cardiac arrest or worse. Well, then you can quickly realize that child was not getting better. And obviously that's what led to our codes about once a month, our 2 or 3 times a year when we seriously harmed a child. So initially we just had our code team, but that obviously was failing us too frequently. So we put in place, like most hospitals, and I think most of your hospitals, rapid response teams. And we found that actually reduced the incidence by somewhat. And then we said that's still not good enough, so we put in an early warning score, just like you all are doing with the news and Pews. And that also reduced the incidence, but we said that's still not good enough. And so we looked at what was causing those last few incidents of harm and what could be preventing them. And that's why we learned about situation awareness. And situation awareness has 3 levels. They're described here as 1, 2, and 3. The most basic level is I can perceive what's going on. In a pilot, that would be a blip on the radar. For us, it's an increased heart rate, or a child not quite looking right, or maybe even a parent saying something, trying to give us a clue that something's not right. The second level is I comprehend that. So for a pilot, that would be, I understand that blip on my radar may be a missile coming at me. And for us, we would understand that heart rate's not normal, that's abnormal. And it means something. Or that parent, they don't normally say those words. That must mean something. Or that child, it's just not quite looking right. I understand that means they're getting sick. And then the third level is projection. I can project what may happen if we, depending on what I do next. And so for a pilot, that's clear that if it's a missile coming at me, I need to take evasive action. Otherwise, my plane will blow up. For us, it's that, well, if I don't give this child fluids, or I don't call the rapid response team, or I don't get them into the intensive care unit, this child's probably going to go into uncompensated shock and eventually, and probably in the not too distant future, lead to a cardiac arrest. And so it's having excellent situation awareness that allows us to make the appropriate decisions every time for every child, no matter who is there. And so what can happen is you can make mistakes and you can miss the important information. I don't perceive it. I didn't see the heart rate. I didn't listen to the parent. I can miss the understanding. I didn't understand that heart rate was going, what it really meant. I thought maybe it was normal, or I thought the mother was just kind of talking. Or I could basically make the wrong prediction. I could say, well, I know it's an elevated heart rate. I know this child looks sick, but I think it'll be okay, or let's just wait till the morning when everybody gets back. I'm sure it'll be fine till the morning. And that's what probably happened at Cincinnati Children's for those 10 cases, or even worse for those 2 children that we seriously harmed. And so we came to understand we had to have a system that for every child that was at risk for deterioration, we needed to identify, we needed to mitigate, and if we couldn't mitigate, we needed to escalate. So we created a system for that. And what our nurses and physicians did, we took a group of about 25 of them, and we asked them to look at the last 25 to 40 children who went from the ward to the ICU. And we said, look at their charts for 6 hours before the transfer, before they had to go to the ICU, and tell us in that chart what you perceive would have been signals that this was going to happen in the next 6 hours. In other words, tell us what would the potential factors were that would allow us to identify this. And at first, as a physician, I have to tell you, I thought it would be all physiologic criteria. I thought it would be, well, it'd all be about heart rates or labs or trends on the blood pressure. And some of it was that, but it was really eye-opening for us to realize that there were other clues that maybe we weren't paying attention to, or at least we weren't saying them out loud. And so the 5 factors, they started with a long list, and then they together worked it down to 5 factors. And the 5 factors, as you can see here in the red circles, it was family concerns. The family was telling us, team, I think something might be going wrong here. Sometimes we listened, sometimes we didn't. High-risk therapy was different for every unit. That was basically, for our area, our ward, we don't normally do this treatment. So chemotherapy may not be high risk on an oncology unit, but it certainly would be high risk on another unit. Early warning score, that was where the physiologic criteria, and that definitely was one of the factors. The 4th one was the one the nurses taught us, watcher. That's their term, at least at Cincinnati Children's, for a kid who just, I got a bad feeling. I can't maybe describe it, but I got a feeling something's brewing here. And the 5th factor was, they called it communication concern, which was a very polite term for saying there's more than one physician team working here, and they're not talking to each other. So what they basically found is every child at Cincinnati Children's who was transferred from the ward to the ICU had at least one of those risk factors, and most of them had more than one. And so that they came to the conclusion, if we could just identify those situations, we could have appropriate mitigation and escalation when needed, we would potentially be able to eliminate these children from having delayed recognition of clinical deterioration. So what we did is we created a system where essentially it was there sometimes when the Top Gun nurses and physicians were there, but it wasn't really anything new, but what we needed to do is create a system so it happened for every child, for every nurse, for every physician. And so we basically assigned the task of identify to the youngest people on our team. It's the interns and the bedside nurses. They may not have years of trend recognition, they may not have seen this year after year, but they were the ones who were the closest to the patient. And so we simply asked them to say, every 4 hours, does your patient have any of the risk factors or not? That was their job. And they had to tell their supervisor, which is really where all the action happens. And we adopted the term for our charge nurses or for our senior residents or consultants of watchstander. We learned that from the military. And it's essentially, if you think about up in a civil aviation tower, you can envision there's people sitting there staring at radar screens and talking to pilots on radios. But interestingly, there's a person standing behind them who's just watching them. And that person's job is to pick out which one of them is looking stressed, which one of them seems to be overworked, which one of them seems to be dealing with a problem, and then go and work with that person. The watchstander is the person who may not be talking to every plane or watching every radar screen, but they're the person with the most years of experience, the one with the trend recognition, and who has a better gut sense of what might need to happen or how risky this situation is. So every 4 hours, our front line is expected to say, does my patient have a risk factor or not? It's not call me if you need me. It's not I'm always available. All you have to do is bleep me. No, it's every 4 hours you have to talk to me and interact with your supervisor and say, yes, I have risk factors, or no, I don't have risk factors. And then the expectation for the watchstanders is if there is risk factors, that's the patient you need to go look at, coach this frontline person, figure out what the situation is, and what we built was an expectation is that the nurses and physicians check it out together and together make a mitigation plan, and they had to write it down. They had to agree. And initially it was the physicians would just say, well, if he looks worse, then we'll do something about it. And the nurses appropriately started pushing back, saying, what do you mean looks worse? And slowly but surely, people started learning, no, I have to say literally what I want you to call me about, whether the oxygen goes up or the heart rate increases by 20 points or the blood pressure goes down or he doesn't respond to this medication. And they would literally write it down. So in essence, what they were doing is taking what was in their head, verbalizing it, making sure they were both on the same page, and then writing it down, which probably is what happened to the Top Gun nurses and physicians for years, but this was the first time that people were expected to be saying this out loud. And we found that they could do it about 85% of the time, but about 15% of the time, there was a problem they couldn't manage. And so we started building a system where every 8 hours, those watchstanders would come together into a huddle. In our place, we have 16 inpatient units that all work together. So every 8 hours, the charge nurses from those 16 units come together, and they have to report out on the status of their unit. And they have to say whether they have any watchers, whether they have a mitigation plan. And we have two people, a senior physician and a senior nurse, who interact every 8 hours with the charge nurses. And they basically look at them in the eye and can get a sense of, do they really feel confident? Do they have a worried look? Do they not quite seem to have a complete mitigation plan? Ask some probing questions in a collegial way. And they do it in front of each other so that they are constantly learning from each other and constantly coaching each other. And the breakthrough came through when one of the senior nurses who oversees this group started asking the charge nurses to predict whether they would have a rapid response call in the next 8 hours. And at first, when we asked them to start saying that out loud in front of their peers, they all said the same thing. I hope not. But I have to tell you, that was about 3 years ago. Now, if you would be at one of these huddles, you would hear the charge nurse say, well, I've got this watcher. I just went in with a senior physician. We looked at him together. We've decided that if this changes, if the heart rate goes up 20 points, or if we have to go up to the oxygen above 5 liters per minute, and that happens before noon, then we're going to call a rapid response team. But I don't predict that will happen. And it's a totally different way to talk about it. And I have to tell you, many of the charge nurses have told us this is why I wanted to be a charge nurse in the first place. It wasn't just to manage staffing. It wasn't just to deal with administrative issues. I'll do that. But this is why I really wanted to be a charge nurse in the first place. So we've built a system of huddles throughout the organization. I've described what we're doing on the inpatient. It's actually spread. It now happens in the operating room, in the pharmacy, and even our facilities people have huddles now predicting what might go wrong with the facilities and what to worry about. But 3 times a day, they have an inpatient huddle where these charge nurses get together. And actually now, at the meeting I was at yesterday, I had everybody listen in, because in the morning, at 8:30 in the morning, all the departments now get together it's a phone huddle, but they each have to report out the status. So this senior nurse who manages the inpatient huddle has to take everything she just heard from all these inpatient units and has to report out to the entire organization by 8:30 each morning in about 30 to 60 seconds what the condition is. Yesterday when we were listening, she said, well, we have 2 watchers that I'm particularly worried about, one on A6 North, one on A5 South, and one of them is predicting a rapid response call in the next 4 hours, but the ICU is aware and they're ready to respond if needed. Totally different than the way it used to be at Cincinnati Children's, when I think we used to think these things were like lightning bolts. They just happened, but how could we have known? Now we start to believe, no, you can actually predict things that we used to think were unforeseen. So the huddle happens. It's a pretty dynamic event, but slowly but surely people have learned that there's actually a system in the huddle with these 16 units never lasts more than 20 minutes. These are our busiest people. These are the people who run the inpatient units. It starts to the minute on time. They each report out. They each have a little less than a minute to report out. And one side note I'll say is that they started all this work, and then about 1.5 years ago, they started telling us, you think we're pretty good at predicting our watchers and who might deteriorate? We can also predict which families are going to get upset as the day goes on. And so now our family relations people actually come to the huddle, and our charge nurses are telling them which family is at risk for getting upset as the day goes on. And so that allows them to start getting out ahead of time also. So it's more than just safety, it's reliability. So finally, let me just show you our data, because none of this matters unless it helps. So one of the things using improvement science we understood is that it's going to be hard to learn if we're getting better if the only thing we're watching is 2 rare events a year or even 1 code a month. And so our physicians and nurses got together and created a definition of essentially a near-miss event. It's a child who didn't code, didn't clinically deteriorate in a way that we missed, wasn't harmed, but boy, they just made it. And so they put this down on paper and defined that a near miss was, which they came to call an unsafe transfer, is a child who got to the ICU from the ward, but in the first 1 hour was intubated, started on pressors, or needed massive fluid resuscitation. Just made it. And I think to some degree in the old days, this is the kind of kid who we used to say, yeah, that's a kid who should be in the ICU. And if he's not that way, don't bring him to the ICU. There was a little bit of tension between our wards and our ICU. But they agreed, no, this was a little too close. So what, my data is missing. Well, all right. Do a little speaker change here and describe the run chart to you. Envision what I'm about to describe to you. I'll give it to you in numbers. We used to average an unsafe transfer. We didn't realize this until we started measuring it, but we used to average an unsafe transfer every 8 days at Cincinnati Children's. Only 2 went on to that serious harm, but just about once a week, one of them just made it. And so it was no surprise that 2 didn't just make it, 2 out of that 50 or so. Now our charge nurses in these huddles and these watchstanders work, we routinely go 45 to 60 days between unsafe transfers, and we've not had a serious harm event from missed clinical deterioration in over 2 years, and we're down to 1 code per year. Now our code team at Cincinnati Children's is more likely to have to do a code on a grandmother who's visiting than they do a patient. And so now they're having to do simulation training on grandmothers instead of children. So I want to give a little bit of acknowledgement, and I'm sorry about the data missing. I think I have it on a thumb drive if anybody wants to see it later. But there's so many people, but a couple of my colleagues, Derek Wheeler and Pat Brady, have done tremendous work on this, and they started publishing some of this. But I hope you get the sense that it's not me, it's not even Pat or Derek, it's these dozens and dozens of people who have really figured out that we can truly have situation awareness as a team, and we don't need to just hope the Top Gun nurses stay all the time. So I'll stop there, and thank you for your attention.